Hello. Mr. Dunn is a pleasant 72-year-old Caucasian male who presents to the clinic today with signs and symptoms of BPH. Mr. Dunn is the primary source of his history. He offers information freely. His speech is clear and coherent. His chief complaint, he states, is that he has decreased force of urine stream, straining to urinate, feeling of incomplete emptying of his bladder, and nocturia times 3. He states that his symptoms are bothersome, but he denies pain. On Mr. Dunn's American Urology Association and International Prostate Symptom Score, he scored a 20 out of 35, which is considered moderate symptoms. The patient states that he is unhappy currently with his situation and scored a 5 out of 6 on quality of life related to his BPH symptoms. Mr. Dunn takes acetaminophen, 500 milligrams PRN for headaches. In addition, he takes a multivitamin. He denies any chronic conditions. He denies any food, latex, or drug allergies. The patient's last testicular and prostate exam was completed in October of 2016. Mr. Dunn denies any history of STD or STI issues or infertility problems. He denies any recent blood transfusions or anemia. Patient is up to date with all of his vaccinations. Mr. Dunn also denies a family history of BPH, prostate, or testicular cancer. Mr. Dunn is married to a spouse named Mary, and they both live together in a 2-bedroom condominium, and they both have 2 children together. The patient states that he usually eats 3 meals a day with snacks in between. For exercise, he reports golfing twice a week during the summer, fishing once a week during the spring, and walking every night with his wife for 1 hour. Patient denies any past or present history of tobacco use. Mr. Dunn reports drinking about 2 to 3 times per month, and he usually drinks beer and usually has 3 beers per episode. He also reports drinking 3 caffeinated beverages per day. Mr. Dunn prefers women, and he reports that he and his wife are in a mutually monogamous relationship. He reports having intercourse with his wife about twice a week. Mr. Dunn denies any changes in his weight, fatigue, weakness, fever, chills, or night sweats. He denies nausea, vomiting, diarrhea, constipation, pain, stomach cramps, bloody stools, or bloody emesis. The patient denies any urethral pain, hematuria, discharge, and testicular bumps or lesions. And he also denies any erectile or ejaculation dysfunction. On to the objective data. Mr. Bob Dunn, his height is 6 feet. He weighs 180 pounds. His BMI is 24.4. Heart rate 76. Respirations 14. Blood pressure 125/85. Temperature 98.6 degrees Fahrenheit. And O2 97% on room air. Upon physical examination, Mr. Dunn is alert and oriented ×4 and is in no acute distress. He's well nourished, well groomed, and dressed appropriately with good hygiene. Upon cardiovascular examination, the patient does not have any cardiomegaly or thrills. He has a regular rate and rhythm and does not have any murmurs, rubs, gallops, or clicks. His upper and lower extremity pulses are 2+. No JVD noted. Capillary refill is less than 3 seconds. Upon GI examination, the patient's abdomen is soft and round without scars or skin lesions. His skin is warm and dry without tenting. His bowel sounds are present and hyperactive in all 4 quadrants. No tenderness to light or deep palpation. He's tympanic throughout. Spleen and bilateral kidneys are not palpable. Upon GU examination, the patient's penis is circumcised without lesions. The urethra meatus is normally has a normal location without discharge. His testes are normal size without masses. His scrotum is without lesions or tenderness. No hernias or inguinal lymphedema noted. Digital rectal exam was completed. He had a normal sphincter tone with no anal, perianal, or rectal lesions. Prostate is enlarged, however, but is under 40 grams, but is non-tender, boggy, or nodule. And the rest of his physical exam is within normal limits. So today, I am going to diagnose Mr. Bob Dunn with benign prostatic hyperplasia with moderate symptoms. Basically, my plan is to do a urine analysis to check for infection, hematuria, and renal disease. And I just got those results back, and they were within normal limits. We will also complete a baseline serum PSA to rule out prostate cancer. His baseline PSA level was 3.5. We also completed a baseline serum creatinine level for the patient, and it was within normal limits. So I will inform Mr. Dunn to continue taking his acetaminophen 500 milligrams PO/PRN for headaches, along with his multivitamin, but I will also add tamsulosin HCl or Flomax 0.4 milligrams PO daily for his BPH. I will inform the patient to alert me if he has orthostatic hypertension, orthostasis, headaches, dizziness, and problems with ejaculation. I will encourage the patient to rise slowly from lying or sitting positions. I will educate the patient to limit his fluid intake to frequent smaller amounts and to decrease his fluid intake after dinner. I will instruct Mr. Dunn to avoid decongestants since these drugs may exacerbate his BPH symptoms. I will encourage the patient to massage his prostate after intercourse and to void more frequently if possible. I would like to see Mr. Dunn in 1 week for a follow-up visit. Since alpha adrenergic blockers work rapidly for BPH by relaxing the prostate smooth muscles, we should see symptom relief in 1 week. An alpha adrenergic blocker such as Flomax is an effective first-line drug therapy choice in the treatment of BPH for men with moderate to severe symptoms of BPH. I chose to use Flomax since it has minimal impact on the cardiovascular system and patients are less susceptible for orthostatic hypotension. However, if Mr. Dunn should develop complications with his BPH, such as hematuria, pain, infection, acute urinary retention, or renal failure, I will definitely refer him to a urologist. Okay, thank you guys. Bye.